And as I talked about before, he's going to talk about something that I think is very near and dear to us, which is pip-tazo breakpoints, particularly with a focus on Enterobacterales. But Tom, I'll let you take it from here.
All right, thank you, Jason. Can you hear me okay?
Yep.
Okay, great. So Jason, thank you for that excellent introduction. Again, I'm Tom Lodise. I'm a professor at the Albany College of Pharmacy and a newly appointed member to the executive committee of USCAST. So today, I welcome you all. It's an honor to present to you, and I'll be discussing some of our breakpoint considerations for piperacillin and tazobactam against Enterobacterales and Pseudomonas aeruginosa. So just a few things with the talk. I'll probably review slides and some materials for about 35 minutes. We'll open it up to discussion. And to facilitate some of your questions, I put slide numbers at the bottom. So that way, if you could direct me to the slide, I can pull it up without, having to randomly shuffle through the deck. So a few things. I mean, just kind of scanning who is in attendance. This is a clinical audience, and we're all familiar with piperacillin and tazobactam. It's one of our most commonly used empiric treatment agents for infections due to Enterobacterales and Pseudomonas aeruginosa. So, despite its wide use, there's been considerable debate on its role for infections caused by ESBL-producing Enterobacterales and AMP-producing Enterobacterales. So, less of a focus on Pseudomonas, more of the concerns have been raised with these two pathogens. So when we kind of look at ESBL producing Enterobacterales, US data indicates that about 15 to 20% of all E. coli and Klebsiella are ceftriaxone resistant. For this presentation, I'm going to abbreviate ceftriaxone resistant as CRO-R, which is a phenotypic marker for ESBL producing Enterobacterales. And when we look at the enzyme that most of these ESBLs are, most of them are the CTXM variants. So a few things about pip-tazo in regard to ESBLs. So fortunately, tazobactam inhibits most CTXM enzymes. However, when we kind of look at surveillance data, what we find is piperacillin and tazobactam has variable in vitro activity against ESBL producing Enterobacterales. So we kind of take a deeper dive and we think about, well, what is driving this variable in vitro activity? What we find is, among many of these ESBLs that harbor CTXM, there's also the co-presence of other beta-lactamases, namely AMP and OXA1, and it's estimated that upwards of 50% of CTXM bearing Enterobacterales co-harbor one or both of these beta-lactamases. Additionally, concerns has been raised with the use of piperacillin and tazobactam for Enterobacterales that have a moderate to high likelihood of clinically significant AMP production, given that tazobactam does not efficiently inhibit these enzymes. So I think we're all familiar with the SPACE or SPIKE acronym. Further research has really tells us we think about some of these Enterobacterales with a high to moderate likelihood of clinically significant AMP production. It really boils down to three pathogens: Enterobacter quakiae, Citrobacter farindii, and Klebsiella aeruginosa. So again, I think we had this longer designation of AMP producers, but those that have that moderate to high likelihood of clinically significant AMP production is largely these three. So, to help us inform our treatment decisions, and I think Jason did a nice job of setting this up. We have various organizations. The two most prominent are CLSI and USCAST. And really what they provide is susceptibility testing, interpretive criteria to help clinicians, guide therapy decisions. So if it comes back, if it's susceptible, indicates a pathogen in which a drug can be used, and intermediate is a category in which there's some hesitation, a risk versus benefit assessment, and then resistant in which the agent shouldn't be used. So CLSI recently, in the past year, updated their breakpoints for Enterobacterales. Again, we talk about piperacillin and tazobactam susceptibility testing. Everything is tested in the presence of 4 micrograms per liters of tazobactam. And what they designated was less than or equal 8 is susceptible. And this is based on a labeled dosing of 3.375 grams or 4.5 grams every 6 hours as a half-hour infusion. They have this intermediate designation, and here they recommend extended infusions of piperacillin tazobactam, either 4.5 Q6 as a 3-hour infusion or 4.5 grams every 8-hour infused over 4 hours. Pseudomonas, which they updated this, I believe it's been 10 years now. The susceptibility breakpoint in contrast is less than 16. Intermediate is 32 to 64, and resistant is greater than or equal to 128. We see similar breakpoints with USCAST. For Enterobacterales, it's less than or equal to 8. Greater than 8 is considered resistant. They still carry that area of technical uncertainty are those with an MIC value of 16. And then lastly, for Pseudomonas aeruginosa, resistant is greater than or equal to 16 and susceptible is less than or equal to 0.001. This may seem a bit counterintuitive because there's really not a designated susceptibility window. However, what this implies is susceptible and increased exposure is required. And really, this is just an indication if you are going to use piperacillin tazobactam for someone with a Pseudomonas infection, the goal is to give maximal dosing so that, 4.5 gram Q6 dosing regimen, preferably as an extended infusion. So as part of our due diligence, as Jason did a very nice job discussing some of our, activities as an organization, we recently also reviewed the susceptibility testing interpretive criteria for Enterobacterales as well as Pseudomonas aeruginosa for piperacillin tazobactam. And kind of looking at the data, and again, thinking about that hierarchy of information, taking in vitro susceptibility, PK, PD, whether it's infection model data or doing Monte Carlo simulation studies, hopefully looking using a population PK model, derived in the patient population of interest. And ultimately, again, at the top of our hierarchy is clinical data. We arrived at different susceptibility breakpoints. So for Enterobacterales, we felt the best thing to do was to look at different types of Enterobacterales, AMC producing, those that are resistant to third generation cephalosporins, and those that are susceptible. So for AMC producing Enterobacterales and third generation resistant Enterobacterales, which really is a phenotypic marker of ESBL producing Enterobacterales, USCAST does not recommend a breakpoint for these pathogens for piperacillin tazobactam. For third generation cephalosporin susceptible Enterobacterales, we landed on less than or equal to 16 as susceptible, greater than 16 as resistant. And then for Pseudomonas aeruginosa, similarly, less than or equal to 16 as susceptible, greater than 16 as resistant. The one thing I will note for, third generation cephalosporin susceptible Enterobacterales and Pseudomonas, these breakpoints are contingent upon a piperacillin tazobactam dosing regimen of 4.5 grams infused over 3 hours every 6 hours. So we'll provide the rationale through this through my presentation today. So a few things, I just wanted to kind of walk you through each one of our recommendations, review the voting and some of the discussion. And as Jason mentioned, these recommendations are pending open comment period. So I strongly encourage you, ask questions during the break. We will consider them. Or either email Jason, but your input is valuable. We discussed as a committee, but I always find the best decisions when we get as much input as possible. So when we look at, so again, our first recommendation is we do not recommend a piperacillin tazobactam susceptibility breakpoint for Enterobacterales species that have a moderate to high likelihood of clinically significant AMC production due to an inducible chromosomal ANC gene. In terms of voting, all 12 voting members were in favor of this no susceptibility breakpoint designation. So in terms of thinking about the hierarchy of information that led us to this recommendation, it was mostly based on in vitro microbiologic data. As most of you are aware, tazobactam does not efficiently inhibit most AMC beta lactamases. And again, thinking about that, there's a high potential for selection of derepressed AMC mutants when administering a labile weak inducer like piperacillin for the treatment of infections due to Enterobacterales species at a moderate or high likelihood of clinically significant AMP production. So again, we think about those three: Enterobacter, Quakiae, Citrobacter, PharmD, as well as Klebsiella aeruginosa. So, you may say that although piperacillin is a weak inducer, is a weak AMP inducer, stably derepressed mutants of these species are usually PIP-tazo resistant. So on the right-hand slide here this is the piperacillin tazobactam susceptibility patterns against AMP derepressed mutants. So this is a paper by Coleman and all, well known to many of us. And again, looking at susceptibility and intermediate, and again, this was all based on the 2017 USCAST breakpoints. What we find is for Enterobacter, Quakiae, and again, they called it Enterobacter aeruginosa at the time, you have less than 10% susceptibility. And, in that intermediate category, you do gain some, but again, if we even look in relationship to the current CLSI USCAST breakpoint, you have, one would argue over 90% resistance. A little bit more favorable story with Citrobacter. However, when you have a stably derepressed mutant, because tazobactam does not efficiently inhibit most AMP beta lactamases, it really is not a viable treatment agent, based on available in vitro microbiologic data. So as Jason indicated, as part of our hierarchy of decision, we also consider, PKP data as well as clinical data. And clinical data also informed our decision. And despite there not being a lot of, strong or robust clinical data, one would consider high quality evidence, the committee, looked at the Merino 2 study and really helped, and the findings from the study really kind of supported our decision not to provide a breakpoint recommendation. So for those who are not familiar with Merino 2, this was a pilot multi-center randomized open labeled study that compared piperacillin tazobactam versus meropenem for definitive treatment of bloodstream infections caused by AMP beta lactamase producing Enterobacterales. So in this study, the primary outcome was they call it a primary composite outcome, but it was, a primary composite negative outcome. So a person was considered to achieve the primary outcome if they had 30-day mortality, clinical failure, microbiologic failure, or microbiologic relapse. So 72 people in the analysis, what we found is that, that primary composite outcome was higher in the piperacillin tazobactam group relative to meropenem. But in part of this trial, they considered all Enterobacterales species that produce beta lactamase, whether it was a low, moderate, or high production. And what I really want you to focus on is the middle there, looking at those who had a Enterobacter infection, or Enterobacter species infection. So in this subgroup analysis, there was 32 individuals. And what we found is, again, numerically, 28% of patients in the PIP-tazo group achieved that primary composite outcome compared to 7% within the meropenem group. Non-significant, it was not powered to do so. But when we looked at this data in combination with the in vitro microbiologic surveillance data, we felt that this was, we felt the best decision to make at this time was not to recommend a breakpoint for piperacillin tazobactam against AMP producing Enterobacterales that, had the potential for moderate to high production. So a few things I wanted to make you aware of, and, I'll do this with each one of our recommendations, some of our key considerations. USCAST acknowledges that the results of real-world evidence studies have not conclusively demonstrated that there is a significant increase with piperacillin tazobactam relative to carbapenems for patients with moderate to high production or high production AMP Enterobacterales infections. So as Jason indicated, again, anytime we see data, we value, we look at the data and assess both, internal validity and external generalizability. So a few things about these studies: they were all of limited sample size. Probably the thing that was most striking to us is selection bias was present. Namely, there was a high risk of confounding by indication. And what I mean by that is the sicker patients in these kind of observational studies typically receive the carbapenem. And, we think about most of our practices, if we do have someone with, and AMC producing Enterobacterales infections, particularly those that have a potential for moderate to high AMC production, most of us are going to lean towards a carbapenem, and this is what we saw in a lot of these observational studies. And also, too, a lot of the studies that did not find an increased risk of failure, they included all species, including those with a low risk of clinically significant AMC production. So it included Serratia, and even included those lacking a chromosomal AMC enzyme altogether. So, again, you kind of look at these data, you really need to drill down and, making sure you have a comparable group with similar disease severity, minimal risk of confounding by indication. And you really need to look at those three pathogens, because otherwise you're going to get kind of a bias towards the null effect. And really, when you kind of have those types of situations, when you have all the different pathogens and differences in disease severity, it's not an ideal study to apply to your patient when making a treatment decision. So our second recommendation, so I think the first one makes sense, clinically, and the second one is a bit different from the other organizations. And, as I mentioned, USCAST also does not recommend a susceptibility breakpoint for Piperacillin tazobactam against third-generation cephalosporin-resistant Enterobacterales. In terms of the vote, 11-1 were in favor of no susceptibility breakpoint. And again, this is pending open comment period. So your input is valued on this. So a few things, we kind of start out, at the, kind of the bottom of our hierarchy of information that we use to inform breakpoint decisions. As Jason mentioned, there's a lot of interest in seeing if there's an ECOF value to help define what the susceptibility breakpoint should be. And this is just, data provided courtesy of JMI Laboratories, looking at the activity of Piperacillin tazobactam against E. coli, Klebsiella, Klebsiella oxytoca, and Proteus mirabilis. So again, there's almost 18,000 isolates here. These are from all U.S. medical centers from 2020 to 2022. And when you kind of look at the overall distribution, it kind of fits, almost a very nice wild type distribution. Yes, you do see some higher MICs, at the outer end of the MIC values. But Elio was kind enough to provide us some of the, the ECOF potential MIC breakpoints, and what you see is, depending on what threshold you use to define the ECOF value, whether it's 95% or 99%, it's 8 or less. And again, if you kind of use that 99% or even 99.5%, one could argue that the susceptibility breakpoint for Piperacillin tazobactam against the Enterobacterales should be 8. However, the one thing I want to draw your attention to is, when you kind of look at susceptibility stratified by, whether it's ceftriaxone susceptible or ceftriaxone non-susceptible, and most people use this not only as a phenotypic marker of ESBL production, but also, a phenotypic marker of resistant to third-generation cephalosporins. Really what you see is two different distributions. And again, when we look at the susceptible isolates, which, predominate here, there's over 15,000 susceptible compared to 2,500 non-susceptible. Most of the MICs are, 4 or less. In contrast, when we start looking at the non-susceptible isolates, we see that MIC distribution shift to the right. And I think this slide really highlights this well. And really what we see is, if we look at the susceptible once again, what we find is the MIC 50 is less than 2. And then, even get up to the MIC 90, you're looking at that 4 to 8 range, depending on which Enterobacterales species you're looking at. In contrast, when we look at, Piperacillin tazobactam's MIC against ceftriaxone non-susceptible isolates, there really isn't any nice pattern to the susceptibility window here. And hence, because of this, because that ceftriaxone non-susceptibility really has a notable impact on the Piperacillin tazobactam MIC against Enterobacterales, we felt that the ECOF was non-informative in helping us to set the susceptibility breakpoint to Enterobacterales overall, even if you pull out those that have a moderate to high production, have a moderate to high potential of AMC production. So the other thing that we considered is, again, kind of saying ECOF cannot be used here. We have a very different MIC distribution for piperacillin tazobactam when ceftriaxone resistant is present. The other thing we would consider was, available PK/PD data. And, we kind of think about a lot of the dosing recommendations for Enterobacterales right now is based on the piperacillin component of piperacillin tazobactam. I think most of us would agree that the PK/PD target is, somewhere around 50% free time above the MIC. And this is just looking at some simulation data, looking at 4.5 grams Q6 hours as a half hour or 4-hour infusion, or, 18 grams daily as a continuous infusion. And really what you find is, looking at, 4.5 Q6 as a half-hour infusion, your probability of target attainment is in excess of 90% for MIC values, less than or equal to 8, which is the current susceptibility breakpoint for Enterobacterales, both by USCAST as well as CLSI. And there's an opportunity to increase the probability of target attainment by either giving it as an extended infusion or as a continuous infusion. And I think some of this data was reflected in, the CLSI's recommendation to have that kind of dose-dependent intermediate designation at an MIC value of 16/4 for piperacillin tazobactam against Enterobacterales. Well, I think these data are reassuring. I think the one thing, we need to realize is when we think about the activity of piperacillin tazobactam against ESBL producing Enterobacterales, tazobactam is the critical determinant, okay? Piperacillin is readily hydrolyzed by ESBLs. So therefore, when we think about the PK/PD of, piperacillin tazobactam against ESBL producing Enterobacterales, we should be focusing more on, are we getting enough tazobactam on board relative, are we getting adequate concentrations of piperacillin? So in recent years, I have all the references at the end of my presentation. There's been a number of in vitro PK/PD models of ESBL producing Enterobacterales infection studies performed. And, the recurrent theme across all these studies is, the tazobactam exposures associated with standard doses of piperacillin tazobactam, even given as an extended infusion, are efficient for restoring the activity of piperacillin against, third generation resistant E. coli and Klebsiella within the range of MIC values currently considered susceptible by CLSI and USCAST. On the right-hand side of the slide, this is just an illustrative example. This is from a in vitro one compartment model. The advantage of this model is, you can mimic, human PK profiles. Also, you provide the opportunity to do intensive sampling, over a 24 or 48-hour period, even longer if you decide to do the study longer, which are a bit challenging for a variety of reasons. And just looking at a CTXM producing E. coli here, what we find is, 4 grams of piperacillin every 6 hours with different doses of tazobactam. And please recognize in all these examples, they looked at 4 grams of tazobactam a day. So with current dosing, we only get 2 grams a day. You get 500 milligrams with each dose. In this study, they looked at a higher dose of tazobactam, either 1 gram Q6 or given that same 4 gram fractionated over Q8, Q12, or Q24 hours. And really what you find is, you get some initial kill, but regrowth is common within the first 8 hours. So again, this is the advantage of this, in vitro one compartment model is, you get to kind of see that initial killing with regrowth, and the regrowth is concerning, suggesting that the drug has limited or the tazobactam exposures are insufficient against this CTXM producing E. coli, which was laboratory generated. So the question now becomes well, what is the tazobactam PK/PD target in the presence of piperacillin against ESBL producing Enterobacterales? And probably the best study that examined this, found that, the PK/PD target for tazobactam in the presence of piperacillin is that, the percentage of time during the dosing intervals that free tazobactam concentrations exceeds the piperacillin MIC with in the presence of tazobactam 4 micrograms per ml. So again, it's a lot to consider. But really what they found is, it's time above the threshold, which we have seen with other beta lactamase inhibitors. And what they identified that threshold to be is the piperacillin tazobactam MIC. So, consider, consistent with standard susceptibility testing, whatever that piperacillin MIC was in the presence of 4 milligrams per ml of tazobactam derived the threshold. Okay, so, the PK/PD target is time above the threshold, which is the piperacillin MIC value. And what they found for the achievement of stasis, you needed 64% free time above the piperacillin, above the piperacillin tazobactam MIC. And again, what we're talking about here is tazobactam concentrations had to be above the piperacillin MIC for 64% of the dosing interval. To get a 1 log kill, which is, really what we look at when we base a lot of our, when we use PKP data to base, breakpoint in our breakpoint decisions, you needed 77% free time above the piperacillin MIC to achieve 1 log killing. And again, this is referring to the tazobactam concentrations. So to put these results in clinical perspective, this is something that Jason did in one of his previous publications. This is the probability of tazobactam achieving free time above the piperacillin MIC of 77%. Again, this was the target associated with 1 log killing. And as you can see here, looking at 500 Q6 with that traditional half-hour infusion, or 500 Q6 with the extended 3-hour infusion, and what he did is that he stratified probability of target attainment based on the creatinine clearance. As we are all aware that, beta-lactams, including tazobactam, are marino eliminated, and your probability of target attainment is largely going to be dependent upon, what is that patient's, renal function, and typically what we use is creatinine clearance estimated patient's renal function. So with traditional infusion, really what you find is probability of target attainment for most renal function groups or creatinine clearance groups was less than 90% at an MIC of 2. And when we look at, even given an extended infusion, what we see in most circumstances, you gain 1, 2 log dilution, and an argument can be made, perhaps it's a breakpoint of 4. Kind of go back a few slides and you kind of think about, well, what is the piperacillin tazobactam MIC distribution against, ceftriaxone resistant, E. coli, Klebsiella, and other Enterobacteriaceae. Many of the isolates have an MIC value in excess of 4. So really we have this accordance between good probability of target attainment and the MIC distribution observed in clinical practice with piperacillin tazobactam against ceftriaxone resistant Enterobacterialis. Finally, in terms of arriving at our decision to no breakpoint, again, kind of sitting at the top of that hierarchy is clinical data. And, I think we had, one of the best clinical trials to be conducted in recent years, which really helped to inform many of our practices, was the Merino trial. For those not familiar with the Merino trial, this was an international multi-center, open-label, parallel group, randomized non-inferiority trial. So the study population in this trial were adults with 1 or more positive blood cultures for ceftriaxone non-susceptible E. coli or Klebsiella that was susceptible to piperacillin tazobactam. As part of the trial for enrollment, susceptibility testing was based on the local laboratory, and most institutions use, commercial susceptibility machines like the Vitek too. The interventions or treatment groups in this trial was definitive treatment with meropenem 1 gram Q8 or piperacillin tazobactam 4.5 grams IV every 6 hours is a 30-minute infusion. The primary endpoint was 30-day mortality. So in total, they enrolled 191 patients in the meropenem group, 188 patients into the piperacillin tazobactam group. ESBLs or phenotypic ESBLs were confirmed in 86% of the isolates. Groups were well matched at baseline. They did some stratification as part of enrollment based on source of infection and PIT score. And really what that was enabled to have a very comparable group at baseline. If anything, the mean Apache score was higher in the meropenem group compared to the piperacillin tazobactam group. So if anything, disease severity was slightly biased against meropenem. And for that primary endpoint of 30-day mortality, 3.7% in the meropenem group, and the piperacillin tazobactam group, it was 12.3%. The difference was 8.6, and the one side at 95% confidence interval, indicated this was a significant finding. And again, if you look at the right-hand side of the graph, what you kind of see is the separation These are the Kaplan-Meier estimates for the primary outcome of 30-day mortality. And really what you kind of see is it wasn't like deaths were kind of all at the end of the study, which may indicate disease severity. Rather, they occurred during that window, which I would consider, deaths to be, highly likely to be related to treatment. And you saw those separation of the survival curves. So a few other things with the trials, in terms of Merino that we also consider. Again, it was not powered to look at this, but clinical and microbiologic response at day 4 was lower in the Piperacillin and tazobactam patients compared to the meropenem patients. Measures of failure were higher in the Piperacillin and tazobactam group. Microbiologic relapse was 4.8% versus 2.1%. Again, these are kind of subgroup analyses. They were not powered to look at this. And the one that really struck us was secondary infections, 8.8% with Piperacillin and tazobactam versus 4.2% with meropenem. And the way to define secondary infections was either looking at development of a Piperacillin and tazobactam or meropenem resistant organisms or development of Clostridium difficile. And really what they found is 6 patients, had a Pip-Tazo or meropenem resistant organism develop. In contrast, in the meropenem group, it was only 6 patients. The other part of this study was looking at mortality in some of the more difficult to treat patient populations. I would argue these are the patient populations we encounter in practice with the ESBL producing Enterobacterales infections. Like most randomized trials, you tend to look at the less sick part or the patients with less comorbidities, in the entire risk pool or the source population with ESBL producing bloodstream infections. When you do look at some of those more difficult to treat populations, you saw some real numerical differences in mortality between those who got Pip-Tazo versus meropenem. PIT score greater than 4, healthcare associated infection, non-urinary source. So again, this wasn't powered to look at this, all the caveats and looking at subgroups apply here, or even secondary endpoints. But there were some notable differences as part of the Merino trial. So in part of their due diligence, the Merino team, kind of went back and, tried to better understand, why do we see this higher rate of mortality with Piperacillin and tazobactam, versus meropenem. So one of the things they did is, as I mentioned before, to get enrolled in the trial, you had to have a Pip-Tazo susceptible E. coli or Klebsiella bloodstream infection. That was all done at the local laboratory. So, as part of the study, they collected as many isolates as they could, and they sent them to a central lab for MIC testing and whole genome sequencing. So of the 320 primary blood cultures, of the 379 patients, they were able to recover 320 primary blood cultures, 278 E. coli, 42 Klebsiella pneumonia, representing 84% of the patient population. So a few things when they did, MIC testing by the microbroth dilution method, or broth microdilution. MICs tended to be higher than those reported as part of the Merino trial from the local laboratory. And what they found is 6% of the isolates were resistant and 20% at a Pip-Tazo MIC of 16 upon retesting. When they just looked at those with a Pip-Tazo susceptible infection or bloodstream infection, the mortality difference decreased to 5%, so -1 to 10%. The second major finding was, kind of looking at, these, with the genome, looking at the genome sequencing, CTXM predominated, which was not surprising, but, as I discussed before, co-production of OXA enzyme was also common. When they kind of looked at the MIC distribution, those with this, CTXM and OXA tended to have much higher MIC values relative to those with just the CTXM. So kind of what we have seen in the literature actually played out with the Merino trial is when you have CTXM with another beta-lactamase, those MIC values, the Piperacillin and tazobactam, tend to be at the higher end of the susceptibility range, reported by other organizations being, 8 or 16. So the one thing now goes to, well, how can we use or look at this data to, inform breakpoint decisions? Now we have, again, not data on all the patients, but a good representative sample of patients. And this is looking at the association between MIC and mortality by Charleston Comorbidity Index, which I have abbreviated CCS, for patients treated with piperacillin and tazobactam. On the left-hand side, really looks at 30-day mortality by the piperacillin and tazobactam MIC. So as part of their investigation, they did a card analysis. And really what they found is, mortality was highest, or the optimal breakpoint was observed among those with a pip-tazo MIC greater than 16. And, a few things about CART, I have used this in a lot of my prior papers. The goal of CART is to identify optimal split in your data. Really to give you two nodes, one group of patients who are at low risk for your outcome, those at high risk. And as part of this CART analysis, what they found is those with MIC value 32, 64 or higher, there were 10 patients, 5 died with a mortality rate of 50%. In contrast, those with an MIC value less than or equal to 16, there was 11.5%, rate of 30-day mortality. So a few things with this, at the higher end, there was only 10 patients. And even if you look at, kind of between MICs less than or equal to 1 to 16, you kind of see this U-shaped curve. So it's not like mortality was kind of increasing in somewhat of a, with increasing MICs, you usually see increasing rates of 30-day mortality. Rather, you see this U-shaped curve. And, what you actually find is the highest mortality rate was among those with an piperacillin and tazobactam MIC value less than or equal to 1. But what I thought was more interesting, and again, Jason always says, is always go to the supplemental data. And what this does is looks at, mortality by the piperacillin MIC and looking at those with a CCI score greater than or equal to 3, or excuse me, by their CCI score. So that's on the next slide. So when you look at it by the CCI score, what you find is among those who died, they all had higher disease severity. As I mentioned, there's a lot of patients included in the study that had a lower disease severity. So when I kind of look at this data here, it really suggests that, it's not so much the MIC value was important, but rather that disease severity really drove, some of the mortality across the whole continuum of MICs considered susceptible by other organizations. So when you kind of look at the data, among the 96 patients with a CCI score less than 3, only 1 died. Of those with a score greater than or equal to 3, there were 17 deaths. So there's always this debate, should we use this in patients with UTI infections or not? 18.8% patients died if their source of bloodstream infections was a urinary source. And for non-UTI source, it was 37.9. And as part of this analysis, again, they did a CART to see if there was an optimal split among those with a non-UTI source with a CCI score greater than 3. Again, 29 patients, small numbers. Yes, they did observe, among those with an MIC value greater than 8, there was only 7 patients. The mortality rate was 71.4% compared to 27.3% among the 22 with a pip-tazo MIC less than or equal to 8. But I would argue in both circumstances, for an ESBL producing bloodstream infections, I would look at 71.4%, 27.3%, even 18.8% among those with a urinary source to be unacceptably high rates of death for those, with an ESBL producing bloodstream infection, based on any treatment they received. This was not considered, acceptable response rates. So a few considerations with our recommendations, again, no ECOF value. And if you look at the non-susceptible isolates, you really see a different MIC distribution. You look at PK/PD data, there's, the tazobactam exposures are insufficient to get 1 log killing in some of the better performed studies. And we also have clinical data suggest that, pip-tazo is associated with a higher mortality rate. So a few things with our recommendation, it was not unanimous. There's 1 dissenting voter. And this voter did not rule out the potential role for pip-tazo for the treatment of complicated urinary tract infections due to 3rd-generation cephalosporin-resistant Enterobacterales, as there's some evidence supporting pip-tazo in the setting. So, I included some of the references there. One was a small randomized trial. As Jason mentioned, as part of our decision making, we always prioritize clinical data at the top. We've reviewed these papers very closely, and some of the caveats I mentioned before, looking at pip-tazo versus carbapenems for patients with AMC producing Enterobacterales infections, particularly those AMC species that have a moderate to high risk of AMC production. Sicker patients tended to get the carbapenem. Limited randomized clinical trial data. And also too, in terms of, why we recognize some of these other data in addition to the issues, with the observation and the randomized clinical trial, there's really not a strong PK/PD story with current doses of tazobactam with piperacillin supporting its use as an option for third generation cephalosporin resistant Enterobacterales CUTI infection. So Jason mentioned some of the things we're discussing. Should be looking at stasis, one log killing. And if you look at stasis, for a CUTI infection, based on best available data, tazobactam exposures are inadequate even for achievement of stasis. So the one thing we all agreed, future research is needed to this area to better define the pip/tazo susceptibility breakpoint against third generation cephalosporin resistant Enterobacterales. Need more preclinical PK/PD studies, the infection model studies that look at a more diverse group of pathogens that produce ESBLs, different species, different enzymes, what in presence of, the presence of CTM with other coenzymes is needed to really help better define the PK/PD story here. And, if we find that, the preclinical PK/PD infection model data supports, further development of pip/tazo against ESBL producing Enterobacterales infections at this point, we think a, future randomized trial would be warranted. We know Peter Penn is ongoing, and we look forward to seeing those results. And we think when we think about randomized clinical trial data, not only is it needed in all types of patients, but I think it'd be beneficial to look at individuals with the less invasive infections, including those with CUTIs, to determine if pip/tazo is still an option for these individuals if they have a ESBL producing Enterobacterales infection. Two more recommendations left, and we'll open up the discussion. For third generation cephalosporin susceptible Enterobacterales that do not have a moderate to high likelihood of clinically significant AMC production due to an inducible chromosomal ANC gene, we recommend that the pip/tazo susceptibility breakpoint be less than or equal to 16/4 and resistant be greater than 16/4. Our recommendation is based on a pip/tazo dose of 4.5 grams IV infused over 3 hours every 6 hours. Similar to the previous vote, the vote was 11-1 in favor of the susceptibility, in favor of both the susceptibility breakpoint and dosing recommendations. So as I showed you before, this is the ceftriaxone. This is the pip/tazo MIC distribution among Enterobacterales that are ceftriaxone susceptible. And here we just looked at E. coli, Klebsiella, and Proteus mirabilis. And, not surprisingly, the MIC distribution really mimicked the overall distribution since it represented the majority of strains. As I already mentioned before, the ECOL value for piperacillin against each Enterobacterales species was less than or equal to 8, depending on where you define your ECOL threshold for defining that wild type distribution. So, again, why one can make the argument that, the ECOL supported a susceptibility breakpoint of less than or equal to 8. USCAST was in favor of a pip/tazo susceptibility breakpoint of less than or equal to 16. And when we think about what was the information that drove this, it was really driven by, PK/PD data, particularly simulation data, indicating that the probability of achieving, 50% free time above the MIC here, we specifically looked at the piperacillin component with extended infusion, pip/tazo 4.5 grams Q6 every 6 hours as a 3-hour infusion is greater than 90% for pathogens with an MIC value less than or equal to 16. So here again, we consider it the MIC, even though we're somewhat, I kind of discussed misapplying the ECOF because you're looking at a part of the distribution, but it's really reflective. It represents the majority of the distribution. We actually want, 1 log, 2 log dilution higher. And the one thing I would say is, we were quite adamant on using the high dose extended infusion and were imposed to extended pip-tazo infusion regimens for patients with third generation cephalosporin susceptible Enterobacterales infections. And the reason for this is simple. So as I showed you before, I showed you some probability of target attainment data with pip-tazo. Most of these studies, the PK/PD target is 50% free time above the MIC, and you get this overall probability of target attainment for each MIC value, in 2 log dilutions, up to some outer value, 64 or 128. So the one thing you need to realize when you look at the results of those types of studies, they take an expectation across all types of patients, including patients with different degrees of renal function. And really what we know is with the beta-lactams, they're renally eliminated. And based on someone's estimated creatinine clearance or renal function, you're going to see a different probability of target attainment. So this is a paper we did a few years back looking at the probability of target attainment of standard dose and extended infusion pip-tazo. Here we just looked at 3.375 grams every 8 hours of 4-hour infusion. And we stratified target attainment by the patient's estimated creatinine clearance. We looked in 20 ml per minute kind of intervals, as well as the pip-tazo MIC value. And what you find with standard infusions, why a lot of these kind of overall weighted probability of target attainment analysis say you get greater than 90% target attainment at MIC values less than or equal to 8, really what you say is, yes, maybe that's true for patients with, lower estimated creatinine clearances, but those who have 80, 120, those who have 80, 100, 120 mLs per estimate, estimated creatinine clearance of, 80 to 120 mLs per minute, what we see is probability of target attainment that's less than 90%. In contrast, in this example here, looking at 3.375 every 8 hours as a 4-hour infusion, what you see is very good probability of target attainment at an MIC value of 8. It begins to decline at 16, hence our recommendation for 4.5 Q6 every 3 hour as 3-hour infusions to ensure you have greater than 90% probability of target attainment and MIC value of 16. So as you may mention, one of the recommendations is part of CLSI for Enterobacterales is the MIC value is 16. You can use 3.37 or 4.5 grams Q6 every 8 hours of 4-hour infusion. And the only caveat I would have to that is, yes, and you look at these overall probability of target attainment analysis, or, it indicates that the PTA is greater than 90%. However, in patients with, higher rates of creatinine clearance, 80, 100, 120, it may be suboptimal if the MIC value is 16. But the one thing, we did note, as part of our investigation is that, tazobactam contributes to the activity of piperacillin, for, ceftriaxone susceptible Enterobacterales or third generation cephalosporin susceptible Enterobacterales. So I think we all work under this assumption is really it's the piperacillin driving that activity, and hence why we looked at, the piperacillin probability of target attainment analysis. But again, this is that, provided courtesy of JMI Labs. And really what you find is using the CLSI 2022 kind of, guidance, if you look at the piperacillin MIC, what we see is a shifting to the left when there's the addition of tazobactam. And this was particularly pronounced in looking at the E. coli isolates. I mean, you look at the piperacillin MIC values, they kind of go flat from 2 to 64, then you see an upward increase in the MIC values. And what we see is when you add that tazobactam, it really improves or drops the MIC value, and we see a similar relationship with Klebsiella pneumonia. So, again, data shows that the presence of tazobactam lowers the piperacillin MICs 50 and 90 by several, log 2 dilutions, indicating that tazobactam is not immaterial to the pip-tazo MIC values against third generation cephalosporin susceptible Enterobacterales. So in contrast, to looking at tazobactam with piperacillin against ESBL producing Enterobacterales, no such data has looked at that among individuals. In here, I just indicated as ceftriaxone susceptible Enterobacterales. So it's really a deficit of data. However, I will make mention, this comes out of the group in Australia. They did find in an in vitro dynamic hollow fiber infection model study, which included a third generation cephalosporin susceptible non-ESBL producing E. coli with a pip/tazo-MIC value of 2 micrograms per liter. Standard and prolonged infusions of piperacillin tazobactam were both found to have rapid and sustained bactericidal activity across 7 days. So this is the only data I can find looking at pip/tazo against a third generation cephalosporin susceptible non-ESBL producing Enterobacterales. The pip/tazo-MIC value was 2. Both standard and prolonged infusion performed well against it. However, there's been no PK/PD assessment studies to determine what exposures of tazobactam do you need with piperacillin against third generation cephalosporin susceptible Enterobacterales. So this is an area that merits further attention. So kind of coming to the end here, USCAST voted 11-1 in favor of these recommendations. And the reason why we made these recommendations, even though we had these concerns, is, because tazobactam does contribute to the activity of piperacillin, even against Enterobacterales when there's no ESBL present. We made this recommendation based on the belief that pip/tazo will largely its use will largely be empiric for these patients, and good stewardship practices will foster de-escalation in most circumstances to a narrower agent. The lone dissenting vote, there's always one, was due to concerns that many institutions will not routinely administer extended infusion pip/tazo or will lack the resource for aggressive de-escalation. And I think these are 2 valid concerns. Also, too, I wanted to mention that, these susceptibility breakpoints were contingent upon a pip/tazo dose of 4.5 grams Q6 every 6 hours as a 3-hour infusion. If institutions find extended infusions infeasible, we would recommend that the susceptibility breakpoint be less than or equal to 8. And again, very similar, you see a recurrent theme here. More preclinical PK/PD studies are needed. I think we're not going to get the clinical data. No one's using piperacillin anymore. We'd have to really think about how we do a comparative study here. So I think the best way to address this answer is the tazobactam exposures sufficient with piperacillin and currently available pip/tazo formulations, to use pip/tazo against third generation cephalosporin susceptible Enterobacterales. Lastly, for Pseudomonas aeruginosa, as I mentioned before, we recommend a susceptibility breakpoint less than or equal to 16/4. Resistant is greater than 16/4. Recommendation is based on a pip/tazo dose of 4.5 grams infused over 3 hours every 6 hours, and we were unanimous in this breakpoint recommendation. Already provided, some of the evidence for, or the rationale for supporting that 4.5 gram dose every 6 hours and 2-hour infusion, still applies here. Again, we look at these probability of target attainment analysis, and we look at identifying a probability of target attainment greater than 90%. As long as the target is the same, it's not going to vary whether it's an Enterobacterales or a non-lactose fermenter. A few things here. But the one thing I would say is, there's been some nice work done by William Hope and Tim Felton. There are some questions, is 50% free time above the MIC the optimal PK/PD target for piperacillin tazobactam against Pseudomonas aeruginosa, especially if it's a high inoculum infection? So I think this is another area where, there's a need for further preclinical PK/PD studies looking at isolates with variant resistance determinants in the context of modern day in vitro surveillance data. But I kind of look at Pseudomonas and pip/tazo the same way I look at pip/tazo with ESBL producing Enterobacterales. I think we're at a point in this drug life cycle where future breakpoint decisions should ideally be based on high quality clinical data if such becomes available. So with that, I'll stop. Jason, hopefully I have enough time for a few questions. But this is just to remind everybody, these are recommendations, no breakpoints for AMC producing Enterobacterales, third generation cephalosporin resistant Enterobacterales, for Pseudomonas, as well as third generation cephalosporin susceptible Enterobacterales. The susceptibility breakpoint is less than or equal to 16 in both for both pathogen groupings. So that'll stop, and I'll hopefully have a time for a few questions.
So thank you, Tom. Most of the comments that I got in direct message were people telling me they'd rather look at pictures of my dog than my face. I think so. That means that you did a really good job. But there's actually nothing pressing right now. So I think what we'll do is let's have a bio break. If people have questions for Tom, we can hit him up with it on the back end of that. But let's have a pause here for 10 minutes and come back at 2:50. We'll address any questions that come up in the interim. Again, you can give us feedback after the fact as well, so that's okay. And if there are no other questions at this time, we will move on to the next presentation. Thanks so much, Tom. That was great.
All right, thank you, Jason.